Hello, my name is Dr. Nicholas Kuntz. I'm a urology resident at Duke University. Today we'll be discussing erectile dysfunction. By the end of this video annotated presentation, it's my hope you'll be able to answer the following three questions. Number one, what is the definition of erectile dysfunction? Number two, what are the risk factors and other possible causes of this condition? And number three, in this day of modern medicine, what are the main forms of management for erectile dysfunction? This is just a brief outline of what I hope to cover today. We'll start with the definition, physiology, and risk factors, and end with the treatments to include medications, surgeries, followed by a brief summary. So from a medical standpoint, it's important to have a common ground when we talk to patients about this issue that can be sometimes embarrassing. So to make sure that everyone's on the same page, in 1993, the NIH Consensus Conference of Impotence gave the following definition for erectile dysfunction: the inability to attain and/or maintain a penile erection sufficient for satisfactory sexual performance. Furthermore, if you're wondering why is this an important topic to be aware of, there was a large study out of Massachusetts that estimated that 50% of men ages 39 to 70 suffer from some form of erectile dysfunction. So before understanding erectile dysfunction, it's important to be aware of the normal physiology of an erection. So the cavernosal artery, as depicted here, delivers blood to the erectile tissue and sinusoids of the corpora cavernosa, also depicted here. The venous drainage originates from tiny venules and venous sinuses that lie just below the tunica albuginea. The neurologic input for an erection originates in the brain from some inciting event. The nerve impulses travel via a parasympathetic nerve chain and cause smooth muscle relaxation and hence dilation of the cavernosal artery. This increases the flow to the penis, causes the penis to enlarge and compress these small networks of venous sinuses. This effectively increases the outflow resistance and leads to an erection. Suffice to say that any derangement along this pathway can lead to erectile dysfunction. Now, normal potency requires an intact and functioning cardiovascular, neurologic, and hormonal systems. As previously stated, you have to have intact arteries and venous blood flow. You have to have an active neurologic components anywhere from the brain through spinal cord and the peripheral nerves. And lastly, hormones also play an important role. Their function overall is fairly complex and beyond the scope of this talk, but suffice to say that any derangement along the hypothalamus, pituitary adrenal axis can cause erectile dysfunction. Each of these components function and are impacted directly by the greater milieu of systemic diseases. Some of the more common culprits are listed here: diabetes, atherosclerosis, liver failure. All these have complex systemic effects that over time can lead to poor erectile function. Additionally, surgery and trauma can also be a major barrier for normal potency. Pelvic surgery and trauma, in general, make up only 6% of all erectile dysfunction. And lastly, there are medications. There are many commonly prescribed and commonly used medications for the general population, notably the beta blockers and thiazides. Moving on to treatment options for erectile dysfunction. These can be organized in a stepwise approach, starting with the least invasive. So the first line is going to be lifestyle and medication modifications. Lose weight, exercise, stop smoking, stop drinking. Consider changing medications if needed. For a select group of the population found to have low testosterone, androgen replacement may be necessary. And today, the mainstay in medical treatment is with a class of medications known as phosphodiesterase inhibitors, and we'll talk about these more later. If these above non-invasive management strategies are unsuccessful, the next step consists of injection of medication directly into the penis. This is known as intracavernosal injection. There is also a transurethral formulation of this medication. Also, vacuum-assisted devices can be tried, and we'll talk about their use briefly as well. Lastly, if all these therapies have failed, surgical intervention has become a common treatment modality, especially with the evolution of the inflatable penile prosthesis. For a specific subset of patients that have vasogenic etiologies, there can be arterial revascularization as an option, but again, this is beyond the scope of this presentation. So the class of medications, commonly known as the PDE5 inhibitors, are well known to the general public, largely thanks to clever advertising commercials by these pharmaceutical companies. But for this reason, it's important that all physicians have at least a basic understanding of how they work. The 3 approved PDE5 inhibitors on the market are listed here by both the generic and more commonly known trade names. The mechanism of action of all these medications are in the cavernosal or arterial smooth muscle cell of the penis. Nitric oxide is released from the nerve terminals from the parasympathetic nerves. These bind to receptors in the cell wall called guanylate cyclase. This enzyme catalyzes the reaction of GTP to cyclic GMP. Now, this molecule basically decreases the levels of intracellular calcium, and ultimately this leads to smooth muscle relaxation and thus an erection. The breakdown of this enzyme, cyclic GMP, is to a compound called 5'-GMP, and this reaction is catalyzed by type 5 phosphodiesterase. Our blockage of this enzyme is the target for medications like Viagra, thus their name. This effectively keeps cyclic GMP activated longer and results in a stronger and more robust erection. Side effects of these medications include headache, flushing, back pain, nasal congestion, and rarely do these cause priapism. The only contraindications for these medications are men taking nitrates for cardiac conditions. This can lead to severe hypotension. If oral medications are not satisfactory, the next line is direct injection of medication into the penis. So this comes in 2 formulations as we discussed earlier. One is a liquid and is used for direct injection into the cavernosal. The other, called MUSE, capital M-U-S-E, which stands for Medicated Urethral System for Erection, and this is a small pellet that is deposited in the distal portion of the urethra. The mechanism of action are the same for these 2 formulations. Once injected, alprostadil binds to and activates the enzyme called adenylate cyclase. This is also located in the smooth muscle cell wall. This enzyme catalyzes the conversion of intracellular ATP to cyclic AMP. Cyclic AMP has a similar action as we talked about earlier for cyclic GMP. It decreases the levels of intracellular calcium, which ultimately leads to smooth muscle relaxation and an erection. Side effects of alprostadil include pain, priapism, and fibrosis, in addition to hypertension and headache. Contraindications for its use are history of priapism, prior penile prosthesis, or pre-existing fibrosis of the penis. Other medications that are commonly used for intracavernosal injection are listed here: piperacin and phentolamine. These are usually used in combination with each other or in combination with alprostadil. Indications for their use are men that have either failed injections with alprostadil or patients that have significant pain from alprostadil. Piperacin works by inhibiting the breakdown of cyclic AMP, as shown here, while phentolamine acts as an alpha-1 antagonist, but its use is only used in combination with other agents. The vacuum erection device is a cylindrical container which is attached to a vacuum. It's secured over the penis, and the vacuum creates negative pressure that draws blood into the penis. Once an erection is achieved, a plastic occlusive ring is placed at the base of the penis, and this prevents blood from escaping. Men who use this device report erections that are comparable in size and rigidity to normal erections, and studies further suggest that patient satisfaction is somewhere between 70 and 80%. Despite this, only 35% use the device long-term. That's a poor attrition rate. The major side effects are listed here. As a portion of the penis proximal to the ring is completely flaccid, this results in a common complaint known as penile buckling or pivoting around this ring. Other complaints are inability to ejaculate, also due to this obstructive ring, and penile coldness, numbness, and pain as well. However, the only contraindication for its use are men taking blood thinners such as Coumadin. And lastly, surgical intervention. This is largely reserved for patients who have refractory cases of erectile dysfunction. There are 2 categories of penile implants that are available on the market today. They are the inflatable and the malleable. The malleable device is always in a rigid state, and the only aspect that you control is the position. Because the penis is always erect, these have high rates of the device eroding through the cavernosa. The inflatable device, also shown here, inflates and deflates with each use. thus the erosion rate is much less. However, it requires a certain level of manual dexterity and hand strength in order to inflate. Complications for both devices include penile shortening, device malfunction, hematoma, erosion, and infection. The rate of malfunction is somewhere between 5 and 15%, and this is measured at 5 years after the operation, and the infection rate is somewhere between 0 and 3%. However, if an infection is present, it usually requires complete removal of the prosthetic. Despite these complication rates, the satisfaction rate for both patients and partners are somewhere between 60 and 80%. Now, the inflatable penile prosthesis has 3 components, as shown here. The reservoir sits in the retroperitoneum just anterior to the bladder. In the flaccid state, this is filled with fluid, while the cylinders, which are located in the cavernosum, are empty. The pump sits in a dependent position in the scrotum, and it's connected to both the reservoir and the cylinders with rubber tubing. To achieve an erection, the pump is manually compressed several times. This action transfers fluid from the reservoir to the cylinders, as shown in this depiction. So in summary, erectile dysfunction is a common condition. As we talked about, it affects roughly 50% of men over the age of 40. The normal erection is a neurovascular event, and there are multiple risk factors that can contribute to erectile dysfunction. Oral medications are the main form of treatment in this day and age, while surgical options are available for refractory cases.